Welcome to Mastering and Guideline in Ultrasound and Echo. Here we have 4 other lecture about optimizing and knobology. Uh, just don't forget check them out. Now let's go for color Doppler. Here are different acquisition mode that are used in ultrasound imaging Doppler, including color Doppler imaging, spectral Doppler, and power Doppler imaging and advanced. Power Doppler imaging and advanced acquisition mode. Usually we don't use in the echo. More we use this two group in vascular app, but the other we use it that we focusing on this two. I talk about all of them in different presentation. You can go check it out and pause it, study by yourself. Now let's go for the color Doppler. Here are those new uh, Doppler application that nowadays we use in the vascular and abdomen and tissue a lot, including B-flow imaging, microflow imaging, super microvascular imaging, and finally contrast enhancement ultrasound. You can pause it and study by yourself. When we hit the color button on the control panel, the machine start goes to mode of the 2D and color and show us the 2D and overriding color Doppler too. For optimizing color Doppler, first we go to the three important parameters. One of them is color box size, color gain, and scale, Corel scale or PRF. First, we go for the size of the color box. Color box generally should be the around the size of the interest area. For example, for mitral valve, when we do here plaques, we have to cover all the mitral valve, not just only the jet. So because the process of the any regurgitation or any other abnormality can happen in any spot of the mitral valve. So we cover from the annulus a little more than annulus of the mitral valve. The height of the color box doesn't affect frame rate, but the width of the color box affect. If it's wider, frame rate decrease. So we want to use the highest frame rate, especially when the heart rate is high, especially in those situations, the sensitivity and accuracy of the color Doppler increased. The height doesn't affect, but still the effect is resolution. So generally, interest area size of the color box is the best. In those cases that frame rate, we need higher frame rate, we can decrease the sector 2D sector 2. Here you can see frame rate from 20 increase to the 22 hertz. On this case that we decrease the uh, sector width. In those cases that we need more higher frame rate, we can use a zoom button at the mode of the color, and 2D we use zoom button. So in that case, not only sensitivity of the color Doppler increase, frame rate increase too. After color box optimizing the size of the color box, we go for color gain. For the EPIC machine, color gain will be around 50 to 55%, but general rules for optimizing color Doppler for color gain is that we crank up the knob bottom of the color that we if twisted clockwise increase gain, counterclockwise decrease gain. We increase gain until blooming starts showing up, means the R spikel of the blood or color show up beyond the blood flow over the wall or even beyond that. You can see on this case the color gain is around 68. It moved 68 to 70, which change it. You can see blooming here, hazy color outside of the blood vessel on the aorta here. So we increase it, then little by little we decrease until the blooming disappear, and we have only at the border of the blood flow and the tissue we have feeling the uh, area. So that is the uh, general rules for color gain in any type of the study. After that, we go for the color scale or PRF. Color scale or PRF for the color Doppler is very important and has very important role in the evaluation of the all blood flow inside of the heart. For echocardiography inside of the heart, big vessels and valves, the frequency, the PRF or color scale should be around 50 to 60, average 55 centimeter per second. And with increasing PRF, our machine become more sensitive to high velocity and in some way decrease or eliminate those low velocity. And with decreasing scale, our machine becomes sensitive more to the low velocity too. So in that case, if we inside of the heart we decrease scale, it has two results. First of all, as you can see here, we have T on the tricuspid in bit PRF 57 centimeter per second. We have very mild trace to mild TR, and the other color during cardiac cycle is normal feeling inside of the right atrium and goes the way, and we don't have turbulence anything. But when we decrease the PRF scale to 23, we will see not only the jet of the TRS size increased, we will have aliasing. As you remember from another lecture, we talk about that differences between aliasing and turbulence. Just a short aliasing is when the velocity goes beyond the Nyquist or Nyquist limit. The machine registers other way. For example, when velocity goes two times of the 23, it goes rapid up and show blue at this level, or vice versa. If it goes other way below about that, it rapid up and show different color on the other side. So we will see a combination of those color at that area that we called it aliasing. The difference between aliasing and turbulence is here that in the turbulence, velocity direction change go from high close to the zero because of the direction, and then change to the other negative way. So there is a border black area between those color changes, that is turbulence. But in aliasing, we don't have this black area border between those two color changes. Just remember. So in those cases that you need we have lower velocity, we have to drop our scale. For example, for intraatrial septum or pulmonary vein or IVC or abdominal aorta, if you want to show better color that area and find the spot and put parts or sample anywhere we want to investigate that area, so it's not bad idea decrease our scale around 40 or even sometime below 40 centimeter per second. Well, after we select color Doppler on the touch screen, those option for optimizing will show up beside of those sector width and color box gain. All we talk about that. There will be other option for optimizing the color Doppler. First, hide color here. You can see bottom is instead of the pushing the bottom to the and color and switch each other every time, we can just touch it color uh, disappear, become 2D, and or vice versa. Color compare we usually use when we want to see exactly the mechanism of any blood flow at that interest area. What is the mechanism and relationship between those structure around, as you know, as you can see here. For example, this MR. Many times, if we are not sure that is, we have defect between the jet come through exactly the valve or no, inside of the valve. We have, for example, perforation. In those cases, we want to see exactly mechanism of the jet. We can use color Doppler together and it show duplex and 2D next to each other. Beside of that, we can use this one, especially in PISA, for detecting exactly where is the base of our isovolumetric area, head of the jet, exactly where is the base. We can compare 2D with color and then measure our radius. Just remember, we have to decrease the sector width for increasing frame rate in those cases with color compare. Black and white suppression just is in decrease or increased the cogenicity of the 2D. Next one is color smooth. This color smooth, almost the function is the same as compounding in 2D. It smooth our color Doppler. Usually we put at the level of low or medium, but we have to see based on the where is that area we are scanning and investigating color Doppler. We can play and see where is the give us the best option for nice and good jet and color Doppler. The next one is a line density. Generally, when we use line density, is determined how many scan and scanning line go through that sector width we have it. We increase in line density, we increase resolution and better quality of color Doppler, but the disadvantage of that is with increasing line density, we lose frame rate. So if you increase, you want to see better color Doppler and don't lose those quality, especially frame rate, you have to adjust those other parameters, including sector width, color box width, all of them, and increase frame rate too. That it make better images. Wall filter has a lot of function for when we use a lot in the echo and vascular, and the main option for main reason for wall filter is that with this option, the machine determine how much of the blood velocity at that level we set it up eliminate. In other words, with wall filter increasing, lower velocity blood flow wherever we have, it has been eliminated in color Doppler. We have both in the color Doppler and spectral Doppler. One of the main reason we use it in eliminate those artifact, especially flash artifact and brute artifact, especially on brute artifact that we have artifact due to the vibration of tissue around that any high velocity and turbulence blood flow is example stenosis. We have turbulence and that turbulence vibrate the tissue around that area, usually vessel, and it can create bruit artifact that goes color around the jet area you can see, or on the Doppler you can see strong at the early of the systole, high velocity, low velocity but strong Doppler. Low velocity, strong Doppler. With wall filter, increasing wall filter, we eliminate this bruit artifact that can be color or tissue and so on. And in the Doppler, we're talking about that. The same, it eliminates all low velocity, means it clean up at the baseline. Above and below the baseline, it clean up and become black. For the another artifact that we have, I talk about that flash artifact that we have it. In those cases that due is those strong structured movement but have low velocity, like the tissue around the heart, sometimes color fill out inside of the color box, or in the subcostal or abdomen with breathing and movement of the intestine, we will see the color box completely become full of the color, that is flash artifact. In those cases, just we have to make our transducer stable, and if this a result of the breathing, patient hold his or her breath, and or scan in different spot that doesn't have those movement of the intestine, or just give it the time until those movements disappear. Another option is frequency of our sound beam. Here, that knob below that, we can change it to the low, medium, maximum. With this option, the frequency of the our sound has been sent a change. In the low frequency, we have lower frequency and lower wall filter. With higher, we have higher frequency and higher wall filter. Generally speaking, when we have deeper area that we want to investigate with color, we use lower. With more superficial, we use higher. And the velocity too. With higher velocity, we use higher frequency. With low velocity blood flow area, lower frequency. As you can notice, they are with this change in frequency, many other options will change. I forgot to mention that when we, most machine, when we change the PRF or scale, current scale, the wall filter will usually change the same direction too. In color Doppler, on touch screen, if we go second page, we will see the other options for the optimizing color Doppler. One of them is, as you can see, persistence. In persistence is the same function in persistent 2D. So we make it our color Doppler smoother, but the problem is that decrease frame rate. Generally for echo, we try to keep it low or off, but for other vascular study, we just play with that one. The next one is, as you can see, color map here. In color map, like the exactly grayscale map, it give us option for different color. Those setup, we can strong, weak. We have many options, 4 or 5 options. We can change it if you want. It doesn't affect on the quality of image, just color change a little. During this color box, we have to remember that when we scan, first things we put color, first we look at the color box. Is that baseline at the 0 or not? Because if it's up or down, above 0 or below 0, the function will be like that. We changing the scale of that level. For example, if we move the baseline up toward the positive, the machine PRF for positive decrease 37 and PRF for the negative shift increase. So it can change the size of the jet and all those measurements. That is the reason only we use it, this baseline changes for the measuring radius head of the jet. Otherwise, we have to make sure our baseline is always on the 0 level. Another one is inverted, that we can invert this one. Usually in echo, we do positive red, show red, and negative, we show blue. And we try not to play with that one. But in the vascular, because we want to see most of the time what is the direction, and our mindset has been fixed for the arterial as the red and the venous as blue. So in those cases, especially lower extremity and in the neck, we change it sometime. But don't forget, when we change it, always mention where the area is that, because that is important for detecting any abnormal blood flow. The next one is variance. As you know, when we have turbulence, high velocity above the Nyquist limit or Nyquist limit, it show turbulence. Instead of the turbulence showing, that we can use variance. This variance show the yellow, the positive and negative at the level of Nyquist limit, red and blue. But when it goes above the Nyquist limit or turbulence, instead of the turbulence shape, it show with the red, yellow, bright yellow or green. So we can detect, our eyes become more sensitive to detecting where is our turbulence and high velocity. We can change it to this variant or not, but a little quality of image in this type, a little change is just the matter of the how we want it. Is not doesn't affect any on the quality of the image. The next one is a right priority. The right priority, it show us that how we want to machine show the whatever the signal come to the machine from that structure. We want to show it as a tissue or as a blood flow. That is the right priority. And this option in the echo, we don't use it too much because usually we have big vessel and big area, the blood flow. But in the vascular, especially a small part like the testis, the thyroid, and all those structures that they are very small vessel, they have very small vessel, and we have flash artifact, or in those that we have cyst and the blood flow feel it inside of the cyst, due to the flash artifact, we can change the right priority and show blood flow and differentiated blood flow from the non-flow. Next application for Doppler is a spectral Doppler, that including pulse wave Doppler, continuous wave Doppler, and tissue Doppler. I'm not talking about the tissue Doppler in this clip. In the strain, we go talk over it. And when we selected any of those two option, continuous or pulse wave, on touch screen we will see that option for optimizing. We have many options for optimizing. First we go fix these two, baseline and scale, because baseline and scale determine how much size and where is the our Doppler, then we get it. And it's very important when we have range ambiguity. As you can see here, we have range ambiguity. The positive here is above the baseline and above the Nyquist or Nyquist limit, so it drop it other side on negative shift, just with the drawing baseline. And if we need it, still we have range ambiguity, then we uh, increase our scale until it show completely that cycle of the Doppler. That is very important. We have to remember, always focus on that one. With these two, baseline and scale, we fix it our Doppler. General rules: the size of our Doppler should be feeling two third of the our background, and at least in each frame we have to see at least 2 bits, better 3 bits. So that is general rules for optimizing scale and baseline. In those cases that we have positive and negative big Doppler, for example, we have AS and AR. In those cases, we increase our scale first, show both of them at the same frame. Then, based on each of them, we go focus and decrease scale and baseline up. For aortic stenosis, for AI, baseline down, scale down. We show more completely AI. Then we go those measurements. We have here other knobs. Compression is the same as dynamic range and compression on 2D. Generally, make it black and white or more white. For example, if you increase your compression, its background a little become noisy. If we want to get more clear, we decrease a little compression. But we have to remember, based on the how much the power of echogenicity come back, we have to play with this and get strong Doppler. Rejection is has different level. Again, it's increase or decrease. The rejection, those Doppler should be rejected. The velocity, kind of the wall filter, but a little different. But generally, the function is that, almost is that. We have speed, how much our Doppler on the screen go faster or slower. If we want to get more uh, beats in our frame, we increase the speed, especially in respiratory variation, so we decrease it less, so it show more bits in each frame of the image. If we just want to do 2 or 3, we increase speed velocity. That generally we do at the level of fast, medium, or fast. Maximum is only we want to check 1 or 2, or patient has very tachycardic over 120, so we increase velocity, speed, highest one that at least we see bigger envelope. The next one, as you can see here, we have a wall filter, sample volume. First, let's go sample volume. We have different options. The size of the sample volume in echo, generally, it will be around between 2.5 to 4, but it's dependent of the area. For example, in those pulmonary vein that doesn't give us very strong Doppler, we can increase it a little more. It get more sensitive to get a Doppler. General rules for the sample volume is that it should be 1/3 to half of the size of interest area. Especially we play with this in those situations. And the next one is our wall filter. The function of the wall filter is the same as wall filter in color Doppler. We increase the wall filter, it eliminates more lower velocity. When we increase wall filter, the Doppler above and below the line disappear. It eliminate those, especially flash artifact and sometimes buried artifact. We can fix it with this wall filter. And the other one is here you can see option how to arrange monitor the duplex and Doppler together, top and bottom, one of them bigger, smaller, or just Doppler duplex, or Doppler duplex on the left, spectral on the right, or just spectral. For example, as you can see here, we option this one, the duplex on the left, duplex on the left side, and spectral on the right side. Here in previous one, I forgot about the option coronary. It has been, if it has been set up in your machine, we can use this coronary option. It changed frequency, wall filter, gain, and is specialized for detecting color Doppler on the coronary artery, especially those in the pediatric. We use it a lot. On the M mode, the option is option for optimizing is limited a little. We don't have too much on that. We have a chromo map. This just show the different color for us. 2D M map is almost the function as X-rays on the 2D. The harmonic, usually we use it. The most important for this optimizing, using angle correction for the M mode, that the new machine, new version, we have it, this option. We change the orientation of our cursor, and the general rules is our cursor for measurement on M mode should be exactly the same direction of the our 2D measurement. Otherwise, always we overestimate those dimensions, especially for the left ventricle on the plaques. And in other situation like the TAPSI and MAPSI, we have to make it more parallel to the movement of our tissue. So we have to use this angle correction a lot in those situations. We have other option. Compression is like exactly dynamic range for the 2D. We have speed, we have here frequency in deeper M mode. For deeper, you can use decrease the frequency. If superficial, increase frequency, it make image better. We have arrangement for displaying on monitor, how we want to show us in the monitor. And one of the most important useful application for M mode is color M mode. As you know, the M mode is a very good application for time event and sensitive. What does mean time event? In those situations that we want to see mechanism of those whatever changes we see and relationship at what time of the cardiac cycle that event happen, color M mode is the best. For example, we want to check if that jet or AI, MR, whatever we have it, is holosystolic, holodiastolic, mid-systolic, late systolic, at which phase and time of the cardiac cycle we have more or less. Color M mode is very useful. For example, here you can see we have a holodiastolic AI, and even some way you can evaluate how much severity is just uh, not quantitative, qualitative of give you idea how much severe that event has. Especially in those situations that we have some abnormal jet, especially in congenital heart disease. In any abnormal jet, is a good idea we use a color M mode at that jet, and it gives us a lot of information about the cardiac cycle and the time of that abnormal jet we have. Next clip will be on strain knobology. Up to the next time. Have a wonderful time.